Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today our topic of discussion is about an intraoperative complication, that is Descemet's membrane detachment, and its possible management. We talk about Descemet's membrane detachment. It is a disease of the posterior cornea. Usually during any intraocular surgery, sometimes because of trauma, or sometimes spontaneously, it gets detached from the posterior side of the cornea, and it can lead to severe consequences as far as the vision is concerned if not properly managed. Usually the patient gives us a history of cataract surgery or any intraoperative surgery, and on examination we will find that severely reduced vision of the patient. Yes, patient's vision is severely reduced. There is severe corneal edema, and you can see also the detached membrane. Sometimes you can also see the margins of the detachment. In this process, we can take the help of anterior segment OCT and UBM, very helpful for demarcating the exact location. But this thing should be taken seriously, and it should be managed, because if it is delayed in management, it can cause further decrease in the vision. As I mentioned earlier, this type of detachment usually occurs due to any intraoperative surgery. For example, phacoemulsification is being done, or extracapsular cataract extraction surgery done. Any intraoperative maneuver is done and the blunt instrument touches the posterior layer of the cornea, and there is a tear formation. Once that tear is formed, then aqueous moves into that area and further detaches this very fragile layer. Even chemical injuries have been assigned that the cause for these things. Sometimes the cornea is so sick, the posterior endothelial dystrophies, that they are very prone to development of these detachments. Person gives during surgery phacoemulsification, he gives oblique clear corneal incision, and that is jagged. So many times it is encountered at those incision sites. So these are the things which can cause to the Descemet's membrane detachment. And also it is quite common in the aged people, 65 years old patients. They can also have this problem. There are different types of classification also. We can say type 1, type 2, type 3. In type 1, both Descemet's membrane and dual layer get separated from the posterior cornea as a single entity. They both are joined together. In type 2, the dual layer is attached, but Descemet's membrane gets detached from there. And type 3, both dual layer and the Descemet's membrane get detached. And all these three classifications can be very easily appreciated on the OCT anterior segment. The management depends upon what is the height, extent, length, and pupil involvement. This is called the health protocol. It can be managed conservatively and as well as surgically. So if we talk about the conservative management, there are different protocols. For example, if the height is more than 300 micrometer and the length is more than 2 millimeter and involving the peripheral cornea, this is one of the way we should go for the conservative management. We will discuss it later on. But if the height is 100 to 300 micrometer on OCT and the length is 1 to 2 millimeter and the central cornea is involved, this is one criteria. The second is if the height is more than 300 micrometer and length is more than 2 millimeter and involving central and peripheral corneas. So in these situations, we have to go for the surgical intervention, that is called, we have to use certain gases or air to get it attached. So this is just generally the different classifications and criteria to go for conservative or the surgical management. Talk about the conservative management, we usually give the topical steroids as well as hypertonic agents. The topical steroids are given to control the inflammation over there, and hyperosmotic agents try to make, as the cornea is edematous, stroma is edematous, so this clears off some fluid from there. So this is the usual conservative management when we decide to control it. So these two agents can be used, and sometimes there are reports that there is a spontaneous attachment of the DESCEMETS membrane. I mentioned that surgical intervention is usually applied for the scrolled edges and non-planar extensive DESCEMETS membrane detachment. Then we have to use either air, or we can use the other one, that is sulfur hexafluoride or fluoropropanes. These are gases can be applied. Usually air is applied when the detachment is superiorly. Yes, we can take the patient to the OR and push the air to mobilize it properly to the location, and then fill up the anterior chamber with the gas, with air, if it is superior one. But if it is inferior DESCEMETS detachment, then as I mentioned, sulfur hexafluoride is a good option. It is completely filled for first 20 to 30 minutes with the gas, and after 15 to 20 minutes, it is 1/3 of this is removed. The only thing is that we have to be very careful about the intraocular pressure. Yes, intraocular pressure should be monitored even while doing this, and post-operatively regularly it should be done. Usually if it is done earlier, this procedure, the chances of success are quite high. Sometimes there is problem in the reattachment. The reason is that once the detachment occurs, these endothelial cells go into a state of shock. So once in that state of shock, their reattachment over there takes time. But even then, this early recognition and management is very important, because if we delay in the management of this, can lead to fibrosis of the membrane. It will not attach, and it will cause scarring over there, which can lead to the permanent decrease in the vision. And then we will land up with DZAC or DMAC to control all these things. So it's early observation. Usually the surgeon performing these things observe it while doing the surgery, that this detachment has occurred. It is at the wound site, or it is central. And when it is a big one central, then the surgery should be done very precisely and carefully, so that it further doesn't extend as much as the, for example, if the phacoemulsification or extra cap is being done, so it should be done very gently to decrease the further expansion of the damage. And this can be done over there. If it is found out during the intraoperatively, then this proper air can be used over there, or as I mentioned, the gas, it can be done during the surgery also. So it is a very important thing to be observed by the surgeon even intraoperatively. Let's have a look at the examples we have here about the DESCEMETS membrane detachment. This is the first patient. Here you can see that the endothelial cell count is okay, 2741, and the patient has undergone the cataract surgery. Operatively, the person has got severe corneal edema. You can see this patient, severe corneal edema, that you cannot even see the anterior segment findings, and it is diffusely involved. This is usually typical of post cataract surgery phaco. You will see such types of edema and DESCEMETS membrane detachment. There's another way to find out this type of detachments along with the OCT anterior segment. So here you can see in the UBM, they have clearly shown that the DESCEMETS membrane has detached in this patient. While posterior segment also mentioned, it's normal, no problem. It's only DESCEMETS membrane detachment shown with the red arrows. Another anterior segment photograph cornea, you can see that how the cornea is edematous over there in that specific area. This is typical, you will see post-operatively after surgery. The narrow slit is formed and showing you the extent of the cornea. Whole corneal layers, stroma, even epithelium, all are involved, and you cannot see even the details of anterior chamber because so much opacity is over there, so much fluid is in the cornea, and the endothelial cells are not pumping it out, so its transparency has gone. So that's why the patient's vision is severely decreased. Almost we can say that it is totally white. It is no more transparent. And different sectors like this you can see over there. Almost it is taking the white appearance because of the severe corneal edema. I mentioned this patient underwent the air. Air was injected to control this detachment, and still there is the air bubble is superiorly present, and there is some corneal edema still present. Again, another photograph, the air bubble is superiorly present, and it is not that much edematous, but still you can see the corneal edema. It is settling down, but still present over there. So this is another OCT anterior segment photograph, much magnified. Here you can see that DESCEMETS membrane has detached, and along with it dual layer is also detached, and they both are separately detached. And please look at the corneal edema, severe corneal edema, and most likely here we can say that this is grade type 3 type of the DESCEMETS membrane detachment, in which both the layers are detached separately. This is the OCT. You can see over there that still some part of the DESCEMETS membrane is detached. It is not completely resolved. So the reason is, as I mentioned earlier, that sometimes you need 1, 2, or 3 sessions of this. The reason is the endothelial cells, one in the state of shock over there after detachment, they take time to come and recover from that shock. Yes, and but ultimately most of the cases settle down and they get attached over there. But this patient in the red square box, this rectangle I have shown you, and that some part of the detached over there, and maybe she will need further treatment. Towards another patient, here you will see that CD is 1788, but if you please have a look at the posterior endothelial cell, it is a sick cornea. The endothelial cells are not healthy. So these types, which are posterior dystrophies of the cornea, these are very prone to such types of detachments during surgeries. So these should be anticipated when the surgeon is planning surgery in such patients. So let's have a look at what happened to this patient. The OCT, you see large central DESCEMETS membrane detachment. To me it looks grade type 2 over there, and whole almost central is involved. And look at the corneal edema after this. Throughout the cornea is edematous in this patient. The corneal pachymetry, here you will see that from 660 it is going up to 850 the corneal thickness. So this is because of the DESCEMETS membrane detachment. So respected audience, this was my topic of discussion for today, that this is a complication which can happen with anybody during surgeries, but the most important thing is early recognition in the normal corneas, early recognition, and it should be anticipated in the sick corneas which have some problems. And once it has been found over there and confirmed with the OCTs, then its management early is very important to prevent the scarring, which is a cause of the permanent vision loss. Yes, once the scarring happens and we delay and we fail in doing this, then we have to land up with DZAC and DMAC, all these things. But once we found it, it is quite easy to manage, although challenging, but it can be managed and the patient's vision can be restored. I want to thank my respected audience for their attendance and attention. I hope this video will be beneficial in their clinical practice. Thank you.